All right, hello, and we'll get started for the webinar tonight. Thanks everyone for joining us today, and appreciate your flexibility. And I think especially nowadays with everything going on, being able to do these webinar series is, I think, very helpful. And hopefully this is a educational experience for everyone, and it's definitely a topic that we're asked about quite a bit. So hopefully this is very helpful. This evening, we'll be talking about total hip replacement surgery. In particular, we will focus a bit on the rapid recovery protocols that we have, as well as the influence of some of the relatively newer surgical approaches that we're using, including the direct anterior approach. For our agenda this evening, we'll begin by discussing the anatomy of the hip. We'll talk about some of the common hip disorders, including hip disorders that involve osteoarthritis, as well as other common hip issues. We'll discuss briefly why hip osteoarthritis hurts and what some of the common symptoms are. Discuss some non-operative solutions for hip osteoarthritis, hip replacement surgery, the potential role as well as the potential benefits of the direct anterior approach as it pertains to rapid recovery. And then we'll save some of the questions more toward the end of the talk. So the first thing we want to do is talk about hip pain and where it comes from. And this is often one of the challenging things that we deal with as clinicians, as hip pain can be very difficult to determine. And we usually try to take an anatomic approach to determine where specifically the pain is coming from. As surgeons, we usually like to determine if the pain is coming from inside or outside the hip joint. So some common areas for painful hip conditions outside the hip joint itself can include issues relating to the muscle around the hip, tendons, bursa, which is normal soft tissue, or even some other related conditions such as nerve pain or sciatica, which is usually referred pain from the lower lumbar spine, or even non-orthopedic conditions such as a hernia, which can masquerade as hip or groin pain. Inside the hip, we look at anatomical structures such as the synovial tissue, which is the lining inside the hip joint, the labrum, which can provide some cushioning as well as stability, cartilage, as well as the bone. This is an image that shows you the left hip. And as you can see here, we have the bony structures of the hip joint itself. The main things to pay attention to are toward the center of the image here, the left hemipelvis, which includes the acetabulum, which is the socket in the ball and socket joint. And then down here is the femoral shaft, which is not imaged, and then the intertrochanteric region here, and then ultimately the ball, which is the femoral head. And it really is the ball and the femoral head and the acetabular socket which forms the bony anatomy for the hip joint. The major soft tissue structure that we look at is the acetabular labrum, which is similar to the meniscus of the knee. It provides further congruency and cushioning inside the hip, and it is potentially a pain generator if injured. This is an image of some of the large muscle groups outside the hip. So this is an image looking from the posterior aspect of the pelvis. And on the left side of the image here, you can see the large gluteal muscle groups. That includes the gluteus maximus here and the gluteus medius underneath it. Toward the right side here, you see some of the very small stabilizing muscles of the hip, which include the short external rotators, which are these small muscles down here, as well as the gluteus minimus and the piriformis. And all these help to stabilize the hip, but can serve as possible pain generators for people with a tendinitis or other soft tissue condition. Some other common extra-articular hip problems can include conditions such as trochanteric bursitis, which is usually related to having a tight IT band, and this can often cause lateral-sided hip pain, burning sensation, difficulty laying down on that side. Tendinitis can occur for really any of those tendons, including the small muscle bellies that I showed you on that last slide. Snapping can occur as well, which can often occur from the IT band, which is the lateral structure, which you see in that picture, or even to the hip flexor. And then last, as I mentioned before, it's also possible to have pain referred from the lower lumbar spine and radiculopathy, which is often referred to as sciatica. When we consider hip arthritis, we have to first begin by looking at the normal cartilage. And so here are some images, some gross images of normal cartilage above and then diseased cartilage below. So normal cartilage is pretty special material. It's very effective at low transmission, and it has a low coefficient of friction, which means that it's very slippery and slick. It's very low friction. And what that does for a normal hip joint or knee joint or other areas is provide a low friction surface for easy and painless range of motion. As you can see from the image below, when you have the absence of the normal cartilage, you have increased friction, inflammation, and that can cause certain symptoms that are very common for hip osteoarthritis. These are some examples of x-rays of the hip. So to the top left here is a normal appearing x-ray. So again, if you look at the anatomy, this is the femoral head, which I'm outlining there. This line here shows us the acetabular socket or acetabulum, and that empty looking space in between actually isn't empty, but that's where the normal cartilage is. And this is what you expect to see in a normal hip x-ray. To the top right here, you see what we often see for patients with severe hip osteoarthritis, which is that that cartilage layer has worn down quite a bit. And in this patient, you can actually see that it's worn down to the point where the bone is actually touching. And we would describe that as severe osteoarthritis. Some other things that we see on the x-ray include small bone spurs. So here you can see evidence of a bone spur, which is a small outcropping of bone that occurs. And that's really a symptom or evidence that the bone has seen some pressure for a long period of time. The other thing that we see, if you look carefully, are these relatively darkened areas in the bone. Those are called subchondral cysts. Again, they're essentially a radiographic piece of evidence to show that the patient has been experiencing hip osteoarthritis for quite some time. And below, you can see how that looks like on those images. A common question people ask is, why is my hip hurt? And it actually makes sense. So as I mentioned before, normal cartilage is a pretty special material, but when you have wear and tear or degeneration of that cartilage, which is what you see in hip osteoarthritis, you have loss of the normal lubrication of the joint and subsequent cartilage injury that can lead to increased friction inside the joint. In addition, when the cartilage layer gets thinned, that leads to increased force transmission to the bone, and that causes pain. The reason why that happens is that the cartilage itself actually has no nerve endings in it. So you can actually wear through that cartilage for quite some time without feeling any pain or discomfort directly. However, when the bone has seen or experienced that pressure or over a long period of time, that can cause significant pain in the joint. Bone spurs, which I mentioned earlier, can lead to limited range of motion and stiffness. And that's really how people perceive, for the most part, the main symptoms of osteoarthritis of the hip, which include discomfort and pain, as well as stiffness. Some other common symptoms include limited ability to walk. So patients often will have a decreased walking tolerance. They won't walk as long as they'd like to, or in more severe cases may even need the use of an assisted device such as a cane. Patients often have difficulty with stairs, going up as well as downstairs. Crepitus is a common complaint. So this is the experience of the joint cracking or popping. Again, that speaks to the lack of the normal frictionless gliding and rolling inside the joint that you typically experience in a normal joint. Pain with prolonged sitting is actually fairly common in hip osteoarthritis, and this may present such as pain while seated in a car or a plane. And then stiffness. And the most common complaints with stiffness are difficulty with socks and shoes, and difficulty getting in and out of a car or a chair. And then last, for some patients that experience their pain or discomfort in a slightly different way is fatigue. And so for people that may have a different experience for their pain or perhaps a high pain tolerance, they may not experience the discomfort or pain directly, but will describe a history of fatigue with activities, and friends and family may comment on the presence of a limp. The terminology can be a bit confusing, including terms such as osteoarthritis, arthritis, degenerative joint disease, and others. But one thing to keep in mind is that regardless of the cause of that thinned cartilage and some of those other accompanying bone changes, the end result is often similar. And so the loss of normal cartilage, the subchondral cysts, osteophyte or bone spur formation can occur regardless of the underlying reason. And so the end result often can be the same. In terms of how we typically like to approach even severe hip arthritis, I generally endorse a conservative approach. And so this is an outline of some of the main things endorsed by the AAOS and the AAHKS, which are our main academic and professional organizations. In regards to the non-operative treatment of hip arthritis, there's a handful of things which can be quite effective. And I generally advocate for trying several, if not all of these things before considering surgery. The first would be medications, which include non-steroidal anti-inflammatories or Tylenol. Physical therapy often can be very effective as well. Wellness and weight loss has been shown in many studies to be very effective for the symptom management of hip osteoarthritis. And weight loss also is very important for patients who consider possible surgical treatments, as having an elevated weight or elevated BMI can be associated with postoperative complications. So it's something to consider. And then last would be injections. So steroid injections or viscose supplementation injections, which patients sometimes refer to as gel injections, both can be quite effective for the management of osteoarthritis. Specific to the management of hip OA, we know that steroid medications tend to be quite effective, and there's relatively less evidence in support of the viscose supplementation injections for hip osteoarthritis at this time. And in general, as I mentioned, we'd like to try all conservative treatments first. However, if you do those things or if the symptoms progress, then it becomes reasonable to discuss operative management, which in the situation of severe hip osteoarthritis entails total hip replacement surgery. So when is it time to talk about surgery? And I tell people that this is a highly personal decision. And the fortunate thing about hip arthritis or knee arthritis is that it's not, generally speaking, a dangerous condition. So it's really more of a issue related to quality of life. So my criteria for appropriate timing, first off and most importantly, you have to have clinical evidence of arthritis, which includes those symptoms I mentioned earlier. And then we want to see corroborated evidence on the x-rays to show that that location of your pain matches your symptoms. In addition to that, we look to see if you're having any daily symptoms, which may include pain, stiffness, or fatigue, as I mentioned. Any limitations in quality of life, such as difficulty with work, limited ability to do recreation, walking, or whatever it is that's important to you personally. And then we like to see if you've attempted any conservative treatment. And again, speaking to the previous things that we mentioned in terms of the non-operative treatment of hip OA, usually involves physical therapy, medications, possibly injections, and weight loss. And ultimately, this is a quality of life decision. This is a video here that I'll show you, which shows you sort of the underlying philosophy of hip replacement surgery, and shows it to you through a video. Before we show it, I'll sort of describe the theory behind this, which is that when you have arthritis of the hip, it's not just an issue of the cartilage. As I mentioned before, when the bone underneath the joint has been seeing pressure for quite some time, you see both microscopic and macroscopic changes, including subchondral cysts, which are very small fluid-filled cysts underneath the bone or within the bone, as well as bone spurs. And so patients commonly ask me, when you have severe hip, knee, elbow, shoulder arthritis, why can't we just inject or replace some cartilage in between? And the truth is that we have actually tried to do a number of things to just put something inside the joint to serve as a cushion. And unfortunately, the issue is that once that bone has seen that pressure, once the bone has undergone those microscopic and macroscopic changes, the surgery that you have to do has to be a combined bone and cartilage procedure. And you'll see how that's depicted here. So we're focusing on the right hip for this image here, and that is the end result, and we'll show you how we get there. So we generally begin with a spinal anesthesia. An incision is made on the hip. The next step is to remove the neck and femoral head, and then we remove any extra bone spurs on the acetabular socket. After that's done, we put a metal socket in place, And then into that metal socket, we insert a plastic cushion or liner, which is that white material there. After that's completed, we then turn towards the femur. So the femur is prepared with the use of broaches, which are specialized instruments which create a special shape, hole, or cavity for the implant to go into. And then the femoral head is implanted onto that, and the hip is reduced. And as you can see, compared to an arthritic hip, which has a high coefficient of friction, painful and inflamed, you replace it with a ball bearing. The one thing that I would addend to this picture is that currently we are no longer using routinely metal balls for the ball and socket joints. So this ball here is a metal ball. Most surgeons now, or many surgeons now, are transitioning toward the use of a ceramic ball, but otherwise the surgery is very similar to that. There's been many iterative changes to hip replacements over time, and the very earliest hip replacements were actually constructed out of ivory over 100 years ago. And obviously since then, we've seen significant improvements, moving away from ivory or other natural materials. In the 50s and 60s really was the advent of what we would consider to be a modern hip replacement. So here we see in the 1950s use of a metal stem, which is more similar to what we use nowadays. Back then, obviously, you still had a metal ball piece on here. And at that point, we were using an all plastic cup or socket. To the right here, we show you a modern hip replacement. So this is the metal stem that goes into the femur. If you look carefully at this, you can see that there's this sort of grit appearing surface. It almost looks like sandpaper on the femur. And it actually is treated to be an ingrowth and on-growth surface. So it's actually made out of this special material, and it's treated in a special way such that after this is implanted, the bone will actually grow onto the implant. And so that encourages long-term stability of this femoral component. On this side here, you see the acetabular socket, such as you saw in that video. And again, you can see that same roughened or sandpapery appearance to it, and this has a very similar treatment. And so on both sides of the metal components, they are designed in a certain way such that the bone will grow onto the implant, and that ensures long-term stability. Inside that metal piece, again, is the white cushion, which is a polyethylene or high density, highly cross-linked plastic, and that serves as a new cushion inside the hip. And then here is the pink ball, which is actually how it appears in real life. It's a ceramic ball. One of the main things that has changed in regards to how we do hip replacements now isn't just the types of implants we're using, it's how we're doing it. And so one of the main changes that's occurred over, I'd say the last 10, 15 years, and really more over even the past 5 years, has been our rapid recovery protocols and our approach to these hip replacements. So this begins in the office before surgery with patient education. We strongly encourage our patients to participate in either a Zoom class or an in-person class when available to learn more about what to expect before, during, and after the surgery. And that patient education is a huge part about having a successful post-operative course. Many of our patients have what we call prehabilitation, which is going to physical therapy before surgery to learn the exercises and really make the hip or knee as strong as it can be before surgery, so that after surgery, you're able to do your rehabilitation quickly and easily, and you leave as strong as you can. For anesthesia, there's been really very significant changes for our pre and post-operative pain management. Most of these surgeries now are done under a spinal anesthetic, which is much safer and leads to decreased blood loss during surgery. It also makes the recovery much easier. For the surgical technique, we have been focusing more on relatively less invasive approaches, which lend themselves to rapid recovery. And obviously that's one of the focuses of this talk, and we'll talk more about that very shortly. And then the post-operative care, I think one of the main paradigm shifts for hip and knee replacements is that we transitioned away from a sick model of care, which meant that you'd come into the hospital, you were treated like you were a very sick or infirm patient and left in bed for several days or even longer, And now we really know that patients that come into the hospital for these issues really aren't sick. They just need to do their rehab and recovery. And so you're treated in a very different way. And so all of our patients that have these surgeries, we really encourage early mobilization, early physical therapy. It's very rare at this point for our patients to require discharge to a nursing facility, and especially in the context of what we know now in terms of the safety profile of nursing facilities. I think that if we can have our patients go home, that's certainly our strong preference, and we think that patients recover much better when they're in the home environment. We also use a multimodal analgesia, which means that we use a combination of different pain medications to decrease pain and discomfort without relying too heavily on stronger medications such as opioids. In regards to the approaches to total hip replacement, I want to start out by saying that, there's many ways to skin a cat in this regard. And as you can see from the image to the left, there's, a half dozen or more. Truthfully, there's probably even more than a dozen described approaches to do a total hip replacement. And, while that's all well and good, by far the most important part of the surgery is this result here to the right. So, you can do a small incision, a long incision, an incision from the front, side, the back, the inside. The most important thing is that you have a good surgical result, which is to have well-sized and positioned implants such that you can mitigate the risk for any issues down the line, dislocation, infections, things like that. So, while we will be focusing on the anterior approach today, I think it's very important to say that, many of these approaches overall can do a very excellent job to do a hip replacement surgery, as long as you can do the surgery part well. In terms of some of the historical background to hip replacement surgery, I think this actually is helpful to understand our rationale and some of the evolution for how this has changed throughout the years. So the original modern hip replacement was actually done initially by actually making a cut to the bone. So the way that this was initially popularized in the 1960s by Dr. John Charnley was to do what we called a trochanteric osteotomy, which is actually a fracture or a cut to the bone that we do intentionally to give us access to the bone and visualize things to do the surgery. And at least for the very first hip replacements, relatively speaking, this did quite well overall. But one of the issues they found was issues related to, the fracture itself, which is that the fracture takes time to heal. At times it may not heal. And even in the best case scenario, it usually results in a little bit of a limp or pain to the area. So in response to that, we really popularized what we call the lateral approach, sometimes known as the Harding approach. And so this was a modification of that technique. And what surgeons did was they modified the approach to avoid making that cut to the femur. And while overall this was also a very good approach in general, one of the problems that surgeons saw was that patients would have issues with gluteal dysfunction and limping, and at times heterotopic ossification, which is the formation of extra bone in the area, which sometimes you can see with an approach that has a little bit more trauma to the tissue. One of the benefits of this approach was a very low risk of dislocation, which is why to this day, the lateral approach is actually still used by many surgeons. For surgeons that were seeking to avoid some of the morbidity of the gluteal dysfunction and the relative detaching of some of the gluteal musculature, the posterior approach was popularized. And one of the advantages of the posterior approach was that it led to less gluteal muscle injury. So relatively speaking, I would describe the posterior approach as a relatively muscle-sparing approach. One of the issues, and I would say one of the main complications of this approach, was the observed risk of dislocation. And the reason why this happened was that for a posterior approach that goes through the soft tissue in the back of the hip, afterwards, that posterior soft tissue remains a bit tenuous. And for patients who have a dislocation, those dislocations are usually through the posterior tissue. And so any violation of that tissue during surgery can put people at risk of a dislocation. And so you had two approaches, both of which were very good overall, but they had their relative drawbacks and advantages. And so the anterior approach was popularized to try to get the best of both worlds. So this is sometimes known as the Smith-Peterson approach. It was actually originally described not for hip replacements, but more for pediatric conditions, severe dysplasia of the femur and of the hip, as well as infections of the hip. So the goal for this was to avoid the gluteal muscle injury that you saw in the lateral approach, but also decrease the risk of dislocation. So again, trying to get the best of both worlds. To show you what these approaches look like in a diagram here will be the lateral approach first. So for a lateral approach, if you can imagine, this diagram is with a patient laying on their back here. So this is the back side here. This is on their front here. Toward the left of the screen is the head, and towards the right is the foot. And so you have a laterally based incision right over the femur bone underneath. When you look at the deep interval of dissection with this purple plane, you can see that the dissection takes you through essentially right in the middle of this large muscle area. So often we'll refer to as a lateral approach as a transgluteal approach because you do have to go through those gluteal muscles. And you can see that in depth here more. So as you go deeper, the main reason why we saw some of those issues with the gluteal muscles was that in order to gain access to the hip during the surgery, you would actually temporarily detach a portion of the abductor tendon from the bone. And that's done obviously intentionally. It's elevated from the femur, and then after the hip replacement is done, that tendon is repaired. And so, overall, once that tendon repairs, it actually functions quite well. So I don't want to make you think that you cut this tendon and you leave it, torn, but it does cause, relatively speaking, a certain degree of trauma to the tissue. This is the diagram of the posterior approach, again, with a very similar orientation. So this is the posterior aspect of the patient here, anterior toward the top of the screen. The head is toward the left of the screen, and the foot is toward the right of the screen here. And you can see a more posterior-based incision. And then really, especially for the posterior approach, you see that you do go between the muscle fibers here of the gluteus maximus, and that does cause a little bit of trauma to the tissue there also. Although, again, as I mentioned before, I would consider this to be a, relatively speaking, a little more of a muscle-sparing surgery for the hip. On the deep layer, you do see here that you do again have to detach some of the very small muscles of the hip to gain access to the hip joint itself. And these are the soft tissues that I mentioned before that once you violate them, as you need to for the surgery, temporarily at least, it does put you at slightly increased risk for a posterior hip dislocation. And so that's the reason why that can sometimes occur. This is what we see for the anterior approach. And so you can see here, obviously the incision is made more toward the front of the hip, really more toward the front of the thigh, really. And then when you look at this purple plane here, you can see that rather than going really through the tendon or through the muscle belly, you're going in between the two major muscles here. So the muscle you see here to the left is called your tensor fasciae lata, sometimes called the TFL. And then toward the right of it is the sartorius muscle. And so by going in between those muscles in what we call an intermuscular internervous plane, you can theoretically avoid some trauma to the tissue. And again, here you can see as you go more toward the deep layer of the tissue, you can see these muscles are sort of pushed off to the either side of the area, and you can actually get access to the hip joint for the most part without detaching major muscle groups. One of the unique aspects of the anterior approach is the positioning. So there's two ways to do this. One utilizes this table here, which is a traction table. So the patient actually lays flat on their back, and then their feet are actually strapped into these traction devices here. These are essentially very similar to ski boots, essentially. And by doing this, it allows the surgeon and the surgical team to position the leg and the hip in a position that's advantageous toward exposure for the surgery. Below here is another version of this surgery, which is actually what I do, which is the use of a regular table and the use of a gel bump. These are the two ways you commonly have surgeons doing the anterior approach, and in my mind, they're very equivalent. For the lateral approach and the posterior approach, one thing that's quite different is that the patient will be on their side We call this the lateral decubitus position. And so one thing that this means for the patient is that we have to position you there. This does usually involve the use of several positioning devices. And then for patients with any issues such as a breathing issue or other conditions that make it difficult for them and their airway, sometimes this does necessitate the use of an airway management. So as I mentioned before, if you are doing a spinal anesthetic, you may not require a tube or airway management, and you see it a little bit more required for a lateral position surgery. Another advantage of that supine position, which is laying flat on the back, is that it facilitates component positioning as well as utilization of intraoperative X-ray, which is helpful for positioning and sizing. And so this is just a tool a surgeon can use to ensure that the components are placed in an adequate position and everything is actually done the way that they expect it to. And so it gives the surgeon some immediate feedback for the surgery while they're doing the surgery. And to me, this is one of the main advantages of this positioning. So some potential benefits. So, these are the things that we typically think about when we consider some of the advantages of a relatively muscle sparing approach, in particular ones such as an anterior approach, is potential for more accurate component positioning, the potential to have less rigorous postoperative range of motion precautions, because again, you're not necessarily violating those posterior tissues. And between these things, it can lead to earlier return to function, potentially less pain, normal walking, less muscle damage and dislocation, as I mentioned before. So those are the potential benefits. But, as we'll talk now, going in the next few minutes, we're actually going to show you some of the studies that look at this. So I apologize in advance. There's a lot of text here, and I know this is maybe going into a little bit into the weeds, but I really wanted to show some of the high level data that we look at that shows the potential benefits of this. So if you don't mind bearing with me for this, I think it is actually fairly helpful. So this is a study that was published in 2018. This was a randomized control trial. So we refer to these as level 1 studies, which means that these are the highest level data that we can. And this was a study out of the Mayo Clinic where they actually randomized patients to either an anterior or posterior approach. So if you can imagine, you go to the Mayo Clinic, you have severe hip osteoarthritis, and you'd like to have a total hip replacement. They sign you up for the surgery, and until the day of surgery, and truthfully, until after you have the surgery, you actually don't know what you're going to get. So it's a very difficult study to do because as you can imagine, it's not something that many people are necessarily interested to leave up to chance. But it really provides some good information to compare the anterior and posterior approach. In this study, they did short-term follow-up. All patients were seen for greater than 1 year. And in terms of the functional outcomes, they found that patients that had an anterior approach had an earlier discontinuation of a walker by a few days, 10 versus 15 days. They were able to discontinue the use of any gait aid at 17 versus 24 days. Their ability to ascend and descend stairs easily was a bit faster, 5 versus 10 days. The patients had decreased in-hospital opioid consumption, decreased pain by visual analog scale, and they also were found to have more steps taken during their in-hospital PT. So there were a couple of measurements they found here that seem to point that these patients tended to have a bit of a faster recovery. Now, there were some things that showed absolutely no difference. So at multiple time points after surgery, the patients were queried for other patient-reported outcomes. And across the board, actually, this showed no difference. So this means that even though patients were objectively doing better and recovering a bit quicker, their perception of the recovery, at least in this study, didn't seem to be much different. They also found no differences in radiographic parameters and no differences in complication rates. So the take home I would take for this study is that, in a level 1 randomized trial, the anterior approach was associated with an earlier functional recovery, but patients generally perceived things to be pretty similar, and there were no differences in complications. And there are other studies with very similar findings. So I don't want to belabor these other studies too much, but these are 2 other similar studies that found that In the anterior group patients, they had slightly increased performance in their ability to wean off of assisted device and the potential for possible better walking scores and differences compared to a posterior cohort. Now, I mentioned that that was a level 1 study, but there were relatively few patients. The next few studies I'm going to show actually had very large sample sizes. And when you look at studies with very large samples, you can actually come up with potentially other useful pieces of data. So this is another very important study from the National Registry from Norway. 21,000 total hip replacements were compared retrospectively. And it's important to note that this was not a randomized trial. So this study actually wasn't designed to look for differences between approaches. What the authors did was they looked at all the hip replacements that were done, and then in a retrospective manner went back to look to see if there were any differences. And so these sorts of studies can be somewhat problematic for that reason, but there are certain things you can glean away from this. So it's important to know that this study was aimed to look at the survivorship of hip replacements or their risk or non-risk of having a failure or need for revision, but it didn't do anything to look at functional outcomes, walking, opioid consumption, or pain. The main takeaway from this study was that they found no differences at all among the risk for need for revision when you compared the various surgical approaches. And this was consistent at both a short and midterm follow-up. When they took a bit of a closer look, they found that there were very small differences between groups, but they were statistically significant, so I'll mention them. One was that they found that the risk of infection was lower in the anterior and posterior groups compared to the lateral, and the risk of dislocation was lower in the anterior group compared to the posterior group. And so while I'll say that this was found in the data, the differences between them actually was quite small, but it is something that the authors found. So, my take home from this is that there were no major differences in the risk for failure when you compare the modern hip replacement approaches, but there were some small differences when you looked at the risk for certain complications. This was an even more recent study with an even larger study group. So this is from the National Joint Registry from Australia. And here they looked at more than 120,000 total hip replacements. So to put this into context, the recent Moderna COVID vaccine trial, which is a very, very large trial and a highly powered study, had roughly 30,000 patients. And so this study had more than 4 times that. So this is a very, very large study. And again, one of the advantages of looking at studies with hundreds of thousands of patients is that you really can look for even minute differences in any factors or risk factors for survivorship in these patients. This study had short-term follow-up, and as I mentioned before, it wasn't really designed to look for any other functional outcomes or other outcome measures other than the risk for needing a revision or redo surgery. And quite amazingly, actually, similar to the other study, they found no differences in overall risk for failure. When they looked more closely at the types of revisions, they found some slight differences. The anterior approach had a slightly higher risk for revision due to loosening of the femoral component. The posterior was slightly higher risk for infection, dislocation, but a lower risk for fracture. And then the lateral had a higher risk for infection. So again, I would say overall, there were no significant differences in risk for major complications requiring revision surgery. And there were very small differences between approaches for the types of failure and revision. And when you look even more closely at the data, at the absolute risk differences between these are on the order of a fraction of a percentage point. So even when you compare the types of revision risks and the different sorts of types of failures you see, these aren't large differences. And so for a study with 120,000 patients, it's so highly powered, we call it, with many people, even with a very clinically small difference, you can see a statistical difference. So that's why we found those differences in the study. Some other things I want to mention in terms of some of the limitations of an anterior approach is the location of the incision. So the incision is located more toward the front of the thigh. So for patients who do have any infection or rash toward the front of their hip flexion crease or sometimes patients with a morbidly obese body habitus may want to consider an alternate approach because you don't want to have the incision in the surgical field in an area that's at high risk for wound breakdown or infection. The anterior approach is not very commonly used for revision surgery or complex reconstruction. And the reason for that is that it's relatively more challenging to extend the incision and the exposure needed if you do a very large reconstruction that you may need to do for a revision. Also, in addition, most patients that have prior surgeries have had some sort of lateral-based approach, a lateral or posterior approach. So if you're removing hardware and you're making a lateral approach and lateral incision, you typically will continue and do the approach through the lateral approach rather than do multiple incisions. The other is that the anterior incision is more visibly noticeable to the patient. And so, while the incision length is pretty comparable to lateral and posterior approaches, most people with a posterior or lateral approach can't see their incisions, truthfully. And so that is one thing that I've noticed is that people, because you're looking at the incision commonly, it's just something that you'll notice more. And the last is that having an area of thigh numbness is common after having the anterior approach. And that's just related to one of the superficial skin nerves that travels in the area of the incision. What I tell all patients for any surgery that we do is that it's very common to have an area of numbness adjacent to the incision. It's one of the things we can't completely avoid when we're making incisions onto the leg. Overall, though, I would say that, and I hope that the takeaway here is that these surgeries are incredibly successful. And at least when I look at those registry studies, one thing that stands out to me is how incredibly consistent the results, and they are incredibly consistent and extremely good across the board. So this was an article from The Lancet, which is one of the oldest and prestigious medical journals. And this was an article that described what they called one of the most important operations of the century, which is total replacement. And I think the reason why they said that was that it really is a highly successful procedure overall, regardless of the approach. I think it's important and helpful to talk to your surgeon about which may be most appropriate for you and have a further discussion about some of the risks and benefits associated with each. But as I mentioned before, the most important thing is to get a good surgical result. So whether or not you do an incision from the front, the side, or the back, as long as you have good component positioning at low risk for things like loosening, fracture, dislocation, that's really the most important thing. And how you get there is probably a little bit less important. The one thing I'll finish again in terms of the takeaway from those studies and the large registry studies are this, which is that, the main thing to consider is that, if you look at the long term, many patients do very well. But, there is a compelling amount of evidence that shows that anterior approach surgery does have a quicker recovery. And so it really is a matter of whether or not that's something that is important to the patient and whether or not the patient is really a candidate to undergo that. So, I hope that was helpful and educational for everyone. And then as you see here, we're going to have a recording of the presentation on the website. So especially if you want to look back and take a look at those slides for the surgery or the approach or even those research studies, you can take a look and see what we mentioned, because I acknowledge there was a lot of information on there. So thanks for your patience and thanks for looking at everything. So we have a few minutes. So what I thought we would do, we have a couple questions people typed in. So I thought I would just go through and answer some of those questions and see if we can answer some of these. So we had someone ask, how do you decide which approach to use and how long, I guess the second question, how long to take NSAIDs before using them is successful? So I'll answer that second question first regarding the NSAIDs. So NSAID use doesn't take long to know. So most NSAIDs have a fairly quick mechanism of action. So for most patients, you should know within honestly a few hours or potentially a few days to know. Typically for an inflammatory condition, taking anti-inflammatories for a few days in a row is usually helpful to really get enough medication. So I would typically think, depending on the condition, you'd want to try an NSAID or anti-inflammatory medication at least for several days, if not longer, to see if that's something that can be helpful. Another question was the how to decide which approach to use, and that's a really good question, and there really isn't a great answer for that. I would say that for surgeons, again, acknowledging that many of these approaches are very good, it comes down to a couple of things, which is the experience and comfort of the surgeon, which is probably the most important. And so if you have a surgeon that you know and trust, and they do a certain approach, I think you can, watch this talk and feel comfortable that any way you do this, you can reliably get a very good outcome. And so I think that's an important thing to mention. And then, as I mentioned before, there's some other intricacies of this which are helpful to know. So as I mentioned before, one of the issues for anterior is that it is by the flexion crease in the front of the hip. And so if I have a patient that has maybe a yeast infection there, or has another surgical wound or other issue toward the front of the hip, now to me, that's a good reason to switch. And I've done that actually recently, where I had a patient, they had an issue for the skin where I typically would make my incision for an anterior approach. And so for that reason, I would never endorse doing an incision right through a skin rash or infection. You never do that. So we decided to do an alternate approach to avoid, making an incision into those tissues. Another question is, was the anterior procedure developed after the posterior? In theory, quote, best of lateral and posterior. So if the patient has faster recovery, why wouldn't every patient have anterior? And so again, that's a good question. And I think, as I mentioned before, certainly one thing we are seeing is that surgeons more and more are increasingly doing more anterior procedures. So when you even look compared to several years ago, 5 years ago, or 10 years ago, when it was very uncommonly done, it is becoming more common. So I think people are, for that very reason, pursuing this more often than they were previously. The other part of it is training. So for an approach that has really become more commonly used, you have to allow some lag period for surgical trainees to have experience in it before they come out into practice. So, now more and more, many trainees that have training in complex hip and knee construction, nowadays it's actually quite rare for hip and knee surgeons coming out not to have at least some exposure to this, whereas it wasn't very commonly done 20, 30 years ago. As I mentioned, the original way was actually to make an osteotomy or a cut to the top of the femur bone, and things have obviously changed a lot since then. Another question here is, what if you need 2 hip replacements, and how do you recommend over one hip if the other is weak? So, I think this really depends on the patient. For someone that has severe hip arthritis in both sides, it is something to consider. There is some data to indicate that your risk of having a complication for a simultaneous bilateral surgery is slightly increased compared to having one. So to me, I would think that there should be a compelling reason to expose the patient to increased risk to do 2 versus 1. And it's not something that I typically recommend, but it's something that we do sometimes, and we take it on a case-by-case basis. I think one of the main things is the need for the patient and also their underlying health status. So someone who's very healthy would be more of a candidate for that versus someone who has multiple medical problems. So the next question here. My mom had both hips replaced a few years ago. She is 60. She had the anterior approach and was standing by the end of the day. Is there a certain approach that is more beneficial or safer or better depending on the type of patient? I really don't think there is. I think that it's a bit agnostic to the age of the patient. For reference, a patient who's 60 years old is actually slightly younger than average. Our average patients who require hip and knee replacements are in their early to mid 60s. So it really isn't something that that I think makes a big difference. And so it's something that I think, again, is really more based on those other characteristics that we mentioned before. And then I think the last one here that we'll mention is related to hip arthritis for surgery, but it's a surgery regarding the use of anti-inflammatory medications, including an NSAID. So NSAIDs include medications such as Aleve, which is naproxen, ibuprofen, which is Motrin or Advil. Celebrex, which is celecoxib, et cetera, et cetera. They're all in the same family. And one of the long-term risks of those medications would be issues related to kidney function. So if you do take an anti-inflammatory on a daily basis or for an extended period of time, I do recommend that you talk to your primary care doctor, because on a somewhat regular basis, maybe once every few months or every other 6 months or once a year or so, they would likely want to get some lab work done. So that's the one thing I typically mention to patients. But for most people, it doesn't cause much of a problem, which is one reason why we typically advocate for them for most of our patients. And the last one was this: if I had a posterior done previously, and if you need the other procedure done, can you have the anterior, or should you have the same procedure on both hips? And so, there's really no reason that you'd have to have the same exact approach done for your other side, even if you had had the other done posterior. This is probably something we see very commonly nowadays, which is we'll see a patient that had a laterally based approach, either a lateral or a posterior approach, maybe at some point in the past, and for whatever reason are interested in having an anterior surgery done, and there's no reason why that couldn't be the case. And it's sort of like a test case scenario. So, these are the patients that often provide us very good feedback. So if for a patient that has had a previous approach and then does have an anterior approach, it does often provide a good amount of feedback to see some of the differences. Although, I will say this, especially for someone who's had surgery years and years ago, there's been a lot of changes, more than just the approach. The medications are a little bit different. The anesthesia is different. So, it'd be easy to attribute all of that to the, where the incision's made. But the truth is that, everything else we do for the rapid recovery plays a role. So, the approach is one part of that. But the truth is that, you can obviously have a very good result no matter how you do it. All right. Well, I think we answered most of the questions there, and we are running out of time here. So I really appreciate everyone joining us for the session. I really hope that it was educational for those of you who sat through the whole thing. Again, I apologize for some of the dry portions for the data, but I thought it'd be sort of interesting to take a look at it, and hopefully that was helpful and informative. So thank you all again. And again, there will be a recording of the presentation on our website. And if you do have a question or another topic or another issue that you'd like to have addressed, please feel free to send us an email at the email address you see there at the slide. All right. Thank you very much, everyone. Take care and be safe.